Hi, everybody. Thanks for joining me today. Um, we're going to get started, and hopefully more people will come in the room, but if it's just a small group, that's all right too. Um, I'm really excited to tell you about our program in biostatistics. So thanks again for coming, and feel free at any time to drop any questions you have in the chat. We'll have a Q&A period at the end, but if we have some extra time, we might answer some questions throughout as well. So let me just pull up our agenda for the day. Here we go. So this is what we're doing. I'll introduce myself. I'm Corinne Riddell. I'm an assistant professor in biostatistics and also in epidemiology. And I am going to be telling you about our program. The next presenter is going to be Joy, and Joy is a first-year student in Biostat. She's going to tell you about her journey to joining our program and about her interest in Biostat and how those developed over time. Ooh, this is a little bit different. There's not a, oh no, this is right, this is right. So we have a quick 10-minute break after Joy's presentation, and then after that we'll be joined by Andy. Andy will talk about some of their research projects and experience in grad school. Andy's a second-year student. Then we'll be joined by Yutong, and Yutong is our DEI Fellow, Diversity, Equity, and Inclusion Fellow, and upper year Biostat PhD student. And she'll be chatting about algorithmic fairness and some of the issues with, I guess, challenges faced by biostatisticians. And then lastly, I'll be joined on the call by Lauren. Lauren's one of our administrators of the program, and we can answer some of your questions, any questions you might have about the program. Okay, so I think everything looks good. No questions coming through in the chat yet, but again, drop them in as you have them. So who are we in biostatistics? So we're a graduate group. That was established in 1955, so been around for a while. The graduate group administers 2 degrees, a master's in biostatistics and a PhD in biostatistics. We're maybe relatively small, depending on other groups you've seen. So we have 12 faculty members, and their primary appointments are in our graduate group, with additional faculty members, about 15, who primarily, like their primary appointments are in other schools like Department of Statistics or Computer Science. There's also some other additional faculty. So at Berkeley, or UC Berkeley, but there's also UC San Francisco, University of California, San Francisco, or UCSF. I'm pointing this way because in the Bay Area, Berkeley, we're over here, and then across the Bay, you see UC San Francisco. And so we have some faculty over there as well that are affiliated with our group. So a variety of people doing different things in biostat that you could potentially work with. So biostat is an interesting degree because it's one of these degrees that really only, like, there's not often undergrad programs in biostat. There's undergrad programs in math and statistics and biology, but not necessarily biostatistics. So I, even myself, hadn't learned about it until I was like an upper year in undergrad. So what is biostatistics? It's easier to talk about what biostatisticians do. So what we do is we analyze biological data, and especially data related to human health, biology, and medicine. So I like to think of biostatistics as statistics, but done on a data set that has something to do with humans, typically. And others can chime in too when they're on the call, but the data I tend to use is always my observations, for me at least, are individual people, and it's something to do with their health. And the other folks, I think they have related data having to do with human health as well. And what I like about biostat is that it allows me to use statistics, which is something I really like doing. I like doing statistical analyses, but on a data set that has to do with people, with the goal of figuring out sometimes like what the risk factors are for certain diseases, or how can we increase like health? How can we make health better? How can we intervene somewhere so that we can maybe give some treatments to improve health or something like that? So we need a process of analyzing that data to make those decisions. And that's one of the things that biostatisticians do. We work oftentimes with large data sets. So statisticians, we really like having a lot of like a big sample size. And so we know how to work with big sets of data. And I think this is one of the things that has really evolved over time with computing power. So we have really strong computers now. Not just do we have like really good computers with good computing resources, we have access to really big data sets. And so as time has changed, as time has went along, we've sort of learned to work with larger and larger data. And that's really variable, I think, across who you're talking to and what their application is. So there's sometimes when I'll do an analysis, and maybe it's only going to have a few hundred people in it, or a few thousand, sometimes a few million. Yutong maybe later on will say the sorts of sizes of data sets that she works with, and I think it's really variable depending on what sort of things you're looking at. But biostatisticians have the skills to work with these really big data sets. So many biostatisticians, in terms of what they studied before they got to biostats, they had backgrounds in math, but others had backgrounds in biology or computer science or another quantitative field. So typically, folks come from one of these quantitative disciplines. I used to think, before I did biostat, I don't have a background in biology. You know, I stopped taking biology in high school, so I felt a little bit like, oh, how can I do this thing with bio in the name? My undergrad was in math and stat, and so that's okay. But on the flip side, if you come from biology and you have less of these other things, that's also okay. But typically from a quantitative field, and I think that sort of makes sense because it's folks from those fields that tend to like to do the sorts of things that biostatisticians do. What are the questions we answer? So I have a few slides on this. So we're going to go through some of these topic areas for the sorts of things that we like to answer. Here at Berkeley, we do a lot of causal inference. And so causal inference is a specific type of analysis where we're really interested in causation, meaning we want to know, does some X cause Y? So does some treatment improve some health outcome? And you probably have heard the phrase, association is not causation. But when you hear that phrase, you're like, okay, what is causation? How do we actually figure out what causes something to happen? And so there's a whole set of methods that under certain assumptions, we can make causal inferences. And those assumptions are really well defined. And so there's a whole field devoted to how to conduct causal research. And a lot of us here at UC Berkeley and the division of Biostat, we do this causal inference research. So an example of one such question is, what are the long-term effects of anti-hyperglycemic drugs on the risk of dementia? So we're interested in these set of drugs. We want to know how they affect dementia. We might use data to answer that come from electronic health records and health registry data, meaning there's these data sets that probably collect like information. I'm trying to think how dementia would be diagnosed through doctor's visits probably. So there's like data sets here in the US, there's like private and public insurance. So you'd have to go to those like health insurance companies or maybe to the public like Medicare or Medicaid, and then pull out some visits, identify where the diagnoses happened on an individual patient, find those patients who were on this drug and those patients who weren't on the drug. But in this data, the complication is who gets this drug is not randomly assigned. So that might mean the folks on the drug and the folks not on the drug are really different. So you can't just directly compare them in terms of their risk of dementia. You need to control for these other things that make these groups of people different. And so that's what one of the really great things that both biostatisticians and epidemiologists are good at is working with what we call observational data. So observational data is data in which we actually we're not experimenters. We didn't randomly assign people to take the drug and people not to. We just said, okay, in this state, maybe some people are taking this drug and some people aren't, but we want to look to see if this drug impacts the risk of dementia. How do we do that when we have observational data? So that's a big thing that we do in causal inference. Okay, cool. So then genetic analysis, what is that? So in genetic analysis, our questions really have to do with the functions of genes or how genes interact. So to answer those sorts of questions, we use high throughput sequencing data to conduct the analysis, and we study how gene variants affect molecular and cellular phenotypes. So how do the genes affect like what you see and how like a person looks and acts and what their outcomes are. This is something I know less about that Yutong will probably talk about later, maybe a little bit, but that's another area of research. So randomized trial design and analysis. So I told you in the first one that we have observational data where we're not like assigning people to treatment or not being on treatment. But randomized data is actually, we're the experimenter and we're conducting like a clinical trial with the goal of, before you do these trials in humans, right, you first do safety and efficacy in animal models. So supposing all of that is done, and we know, okay, the drug looks safe at this dose, there appears to be some evidence that it works among animals, let's see if it works among humans. Then when you do a clinical trial, you are like randomizing people who enroll in your study, some of them to take some drug and some of them to not take the drug. I'm saying drug sort of generally here. It could be like a different sort of treatment. So it could be even how a specific drug is implemented in terms of like, you want to like increase use of the drug. So how do you design it so that people will uptake it and will stick to your treatment? And then we do comparisons across the group randomized to receiving the treatment and those not, to make inference on these health outcomes we might be interested in. So some of the folks that work here in the division specifically do some HIV research in Kenya and Uganda. All right, so here are some other questions we look at. Disease modeling. This one such question is, what's the role of novel mosquito control strategies in eliminating diseases such as malaria, dengue, and Zika virus? What data sets are most informative for characterizing mosquito and pathogen populations to support intervention planning? So John Marshall, if you're interested in this sort of question, John Marshall is the professor here that's working in this area. His whole lab is devoted to this idea, or to this question of disease modeling and looking at mosquitoes and eliminating these diseases. So a really interesting area that is one of the things we do. This next question on health disparities is really US-based. This is actually work that I was involved with. So the question was, how does traffic-related air pollution impact the risk of preterm birth for Asian, Black, Latina, and white mothers living in Oakland and San Jose, California? So to answer this question, we had a really unique data set. So you may be familiar with like Google Street View cars, right? So these Google cars drive down streets so that when you're on Google, you can drag that little person, right, and see different areas. But really cool researcher here convinced the Google Street View cars to monitor air pollution. So they just took those cars that were driving around anyway and equipped them with climate monitors that could measure air pollution. And then they got the cars to drive around a few more times than usual. So they said, oh, drive down like these streets in Oakland and San Jose, which are really close to where we are in Berkeley, and drive down the streets multiple times and measure the air pollution. It's something like every 30 meters, like a really granular scale. And then they just measure black carbon, nitrogen dioxide, things like that. And they're driving down the streets and they're getting all these measurements. So that's how we measured air pollution in this study. Whereas normally air pollution, you might measure it with these monitors that are only every few kilometers. But now we have this grid of measurements along the streets where people live. And so what we did is we took that data and we linked it to the birth certificate data by maternal residence. So we know where mothers lived, and then we were able to link that data to their closest measurements of these air pollution. And then we are asked this question: does living in places with higher air pollution impact the risk of a baby being born early, being born preterm? And we looked at that separately by different racial and ethnic groups because they have these different background risk factors and background risks of preterm birth. So that's an example of research in health disparities that we conducted. Okay, another area that we focus on is precision public health. So precision public health is all about how do we give treatments to patients sort of and try to individualize their medicine. So one question is, how can we best predict patient outcomes and recommend interventions to improve those outcomes, specifically here for acute trauma patients? And again, we have electronic health record data, and that data might be collected through emergency room visit or folks visiting trauma units. So we have all this information about a person, and we build a predictive model to say, considering all these things we know about the person, what treatment might be best for them based on all of these characteristics of them. So that's called precision public health, where it's not just like one pill for everyone. It's sort of saying we'll give a different intervention or different medicine or different exercise, whatever it is, based on unique things we know about you. So that's a really promising area and something a lot of folks in the biostat group work on. Another area, or this is more of a technique, is targeted learning. So targeted learning is a method that brings together, we talked a little bit about causal inference. So it brings together things from causal inference with techniques from machine learning and statistical theory. So all those things are brought together under this technique called targeted learning. And with targeted learning, what can we do? We can deliver better or more precise answers to these causal questions, and at the same time, quantify how our uncertainty. So statisticians are really careful about when they give you an answer like, does X prevent Y? When they say, they won't just say yes or no, they'll have a measurement of how certain they are. So the easiest way to think about this is if you had a study population that only has 10 people in it, that's quite small. And so it's better to have 1,000 people in that study population. So if you made your conclusion based on only 10 people, there'd be more uncertainty than if you had 1,000. And so when we give you our answer about, based on this population, what's the chance that X prevents Y, we'll give some information about how certain we are based on things like the sample size. We're really careful about that particular thing, precision in biostatistics and statistics generally. Okay, so another area is statistical learning machines for the analysis of electronic health records. So you see this theme of electronic health records comes up a lot. So oftentimes there's this data that's being collected from emergency room visits, any sort of doctor visits, and things like prescriptions. There's all of this data out there in the world, and they all live in these electronic health records. And so it's one of the main sources of data that biostatisticians use. And so one of the things we can do is calculate the real world comparative effectiveness of different treatment approaches. What does that mean, real world? Is I think, again, this distinction between if you conduct a randomized controlled trial, that's within a small group of people, but it's super important, right? We do these randomized trials because we can randomize people in a clinical trial to like be vaccinated or not. And that the fact that we experimented or randomized allows us to reduce the risk of there being other differences between these two groups of people that lead to one group doing better or worse than the other. But once the trial is done, say it's done on 10,000 people, then say, okay, we're going to bring this drug to market because it looks effective in these 10,000 people. It reduced the risk of heart attack or something. So then it's used in the real world, and then it's used across millions of people from different groups and from different countries. And then you're going to collect data, you could potentially over 10 years or 20 years. So you could look at long-term outcomes that you weren't able to look at in the clinical trial. The other thing you can do is maybe there's something different about how the treatment approach is used. So like what dose of drug is being taken for how long? Are people going on and off treatment? Are they continuously on it? So you could investigate the different sort of treatment approaches. Maybe one of the approaches is better than another. Maybe it's better to stay on the drug for a long period of time, or maybe not. You know, maybe there's some adverse health outcomes that we only see after a long time. And so biostatisticians analyze that kind of data. Complex treatment effect heterogeneity. So that's a word that we say all the time in biostatisticians that I don't know if anybody else says, but heterogeneity is all about like, is the treatment, how good the treatment is, does it vary by something about the person? Maybe it's more effective in older people than it is in younger people, or something like that. And so we look at what subgroups benefit most, and we try to figure out that information. And that sort of starts to be related to this idea, again, in precision medicine. So which patients should get which treatments, when to modify or intensify, meaning like when to give higher doses or lower doses, or a different dosing mechanism, for example. And so again, this is work that's being done as part of this joint initiative for causal inference, which all of these images are just different groups that are part of this. And so you see Berkeley's here, and then we have like some pharma folks, we have some folks from University of Copenhagen. Kaiser Permanente is they provide healthcare in Northern California, but other places as well. So they have a lot of the data, National Science Foundation, etc. Okay, I'm going to keep going because I have 7 minutes left in my part. Where am I? Okay, I'm going to talk a little bit faster. Well, maybe I'll say less, but not faster, because I know I'm talking fast. This is about clinical trials. So when we have clinical trial data, we can do more sophisticated things with it than just running one trial. We can run many, combine the results, integrate data from the trial to the observational data, and so on. So if you're interested in clinical trials, this is a place to do that sort of work as well. And we talked about precision in public health. So I'll leave this slide up for a second, but I won't say too much about it. Oh yeah, there's all these different things that we do. Lots of the adaptive trial designs are adaptive, designs sort of take in information as you go to allow you to make changes along the way to how you're analyzing something, etc. Okay, but yeah, we do research across many topics. So we just talked about a few of them. But some folks also do neuroimaging, computational biology, statistical genetics, or specific, we get data from specific places. There's a group that does trauma research and critical care. I myself do a lot of perinatal work, so work with on like mothers and babies and so on. So there's a variety of interests among the faculty that are here. So I'm going to spend the next few minutes just telling you a little bit more about the programs themselves. So our program vision is to train future leaders at the cutting edge of developing and applying rigorous statistical methods to real-world problems. So I think you probably have a sense from what we just chatted about that the sort of data we have is really like exists in the world, and there's specific questions we want to answer. And like oftentimes it's all about like how do we best treat a condition, or how do we reduce a bad outcome, or we improve health, or decrease like disparities in the health outcome between different groups. How do we do this? What our core principles are, as we're gonna, tackle these real world problems. We use something called our principled roadmap, which is having to do with this causal inference piece. It's like, how do we specifically do causal research? We follow this roadmap. And so if you came here, you would take courses in causal inference and learn about that roadmap. There's formal benchmarks that we use to like monitor our models, make sure we're doing things correctly. And we're also aiming for diverse student and faculty. And the reason, of course, is that we recognize that biostat requires this immense variety of talents, skills, and backgrounds. So we have these two programs, the master's or the MA, Masters of Arts in Biostat, and the doctoral degree, the PhD. The master's program is 2 years. And you could either do a thesis paper or a comprehensive exam. And so that's a decision you make once you're here, which of those things you want to do. Many people choose the thesis paper, but every once in a while, somebody who wants an exam rather than thesis paper. There's courses folks often come in taking that are strongly recommended, 2 calculus courses, and 1 linear algebra course. And there's a wide range of internship opportunities. This is something great about being in biostat, is like the skills you gain from a biostat degree are super valuable. And our students are in the summertime typically doing internships all over the place. And the nice thing too about those internships is maybe you're like, I don't know if I want to stay in biostat forever. Maybe I just want to do statistics, or maybe I want to go to industry and work in tech. All those internships, they're very happy to work with biostat students because they know your skills are transferable. And so we have folks doing internships in research and biostat specifically, but also people working at Uber or like one of the tech companies, Google, et cetera. If you're in the MA program, there's this pathway to PhD where you apply to the PhD program from the MA program. And so that's pretty common. And you would do that application in the fall of the 2nd year of the program. These are the courses that our MA students take. So you can just read their titles here, and also some additional core courses. A capstone seminar, that's something that I teach for the MA students to help them with their writing of the thesis, but also give more skills, things like how to conduct peer review of like if you're reviewing somebody else's paper, or how to interview for different jobs, things like that we put in the capstone seminar, things that we think are important for our students that don't necessarily get taught in the other classes. Okay, the PhD program, this would be if you already had a master's degree from one of these fields, or like from biostat or stat. Some folks, it's not common that we have people come directly to the PhD, but it does happen, and they have previous degrees in these other areas. In terms of funding, lots of funding opportunities through what are called GSIs, which are graduate student instructors, so helping teach labs and grade assignments for specific courses, or doing student research, that's called the GSR, or a fellowship or internship. So these are all ways that students are funded. Those positions come with what's called partial and full fee remission and a monthly salary. And there's also different training grants. And I know I'm rushing through this part, but we can certainly talk more about this in the Q&A. There's 20 minutes for Q&A at the end. So please feel free if you have any questions about funding to ask. There's a little more information here. So there's some non-residential supplemental tuition that's covered by the division in the first year for PhD students and some master's students. But if you became a U.S. citizen or permanent resident, you can establish California residency after your first year. A U.S. resident or citizen, sorry, can, and PR folks can. International students complete qualifying exams by the end of their first year in the PhD program to be exempted from this, what's called NRST, this supplemental tuition. Okay, so I know I'm at my time. I think I'll just end it by saying that our alumni go off to some amazing places. They get really good positions. Our division has this commitment to diversity, equity, inclusion, and we can tell you a bit more about what we're doing in the Q&A if you're interested in learning about that. And the application requirements and tips are, I think would be very similar to what you would be required to do in other programs. But since we don't have time to talk about this now, we can come back to this at the end. Just let us know in the chat if that's something you want to chat more about. But just for the purposes of staying on time, I'm going to keep sharing my screen, but Joy is going to join us and speak about how did I find my interest in biostat in grad school. So thank you so much, Joy, for joining us. And I can just tell me when to click through.
All right. Hello, everyone. Can you hear me?
Yes.
Okay, great. Thank you, Corinne, for that presentation. It just took me aback a couple of months ago when I listened to the recording from the Biostatistics website. And I remember being very excited after because I had so many questions and uncertainties. So it was really very reassuring to listen to this. I'm happy to be able to share with other prospective students today. So my name is Joy Nakato Zora, and I'm a first-year master's student at the Biostatistics Division, School of Public Health, UC Berkeley. Next slide, please. Yeah, so that is me at the School of Public Health. Just so you all know, the School of Public Health is housed in one of the most amazing and beautiful spaces here at Berkeley. I tell that to everyone I meet. It's really beautiful out there. So yeah, next slide, please. Yes, a little bit about myself. An international student from Uganda, East Africa. And that is where I have lived for the past 24 years. And so I moved to Berkeley about 2 months ago. I'm still, fresh and new here. But so I went to Makerere University. That's where I did my undergraduate program. And I did Bachelor of Science degree, physical. I was a math major, physics minor. Yes, Makerere University is also, that there is my picture on my graduation day. It's, yeah, I'm not yet over it. But yeah, Makerere University is one of the iconic universities on the African continent. We'll be actually celebrating 100 years this year. It's been a great institution for decades. It's, has great alumni, some of which are presidents of some of the African countries. So really glad to have attended that. And so yeah, I'm also a Mastercard Foundation scholar. Mastercard Foundation is the program that is funding my master's education at Berkeley, and I'm happy and grateful for the support. Next slide, please. Yeah, so that picture is from the wonderful team of researchers that I was working with back in Uganda before I joined Berkeley. And I was working at an organization called Uganda Virus Research Institute, IRV, HIV vaccine program. And basically UVRI IRV conducts HIV vaccine trials. However, they diversified into other infectious diseases, but their main gist is HIV/AIDS. Yeah, so that there is me in a red, and under the red, if you can spot me there. And I think this was the World AIDS celebrations in 2021. And we had a couple of journalists come to talk to us about the work that we were doing. Next slide. Yeah. So I joined UVRI IRV shortly after completing my undergrad. That was in January 2021. And I first joined as a graduate intern, and then I was later recruited as full-time staff. I worked with the data and statistics department, which basically performed data management for the clinical trials that were being conducted. And it was a very exciting space for me because I came from a math degree, and, you know, people would ask me, so what is a mathematician doing here? And I was just, open-minded, and I wanted to learn as much as I can. It was my first time to be in a research environment, which was really thrilling because there's lots of things for me to learn, especially about clinical trials. And I think that is where I got my genuine interest in clinical trials. Among the roles I performed was a review of source documents, designing of databases and survey tools. I did some descriptive analysis of data from the community hubs that we had as an organization, where we were performing HIV testing and counseling, and worked with several electronic data capture systems like RedCap, Advantage eClinical, and iMeditant. Yes, so some of the projects I worked on, one was a phase 3 randomized clinical trial under the HPTN Trials Network that was investigating the efficacy of a long-acting injectable cabotegravir compared to a daily oral TDF-FTC for pre-exposure prophylaxis in HIV uninfected women who are at risk of conducting HIV/AIDS in fishing communities around Lake Victoria. So the main target population for the organization I was working with was fishing communities around Lake Victoria, because most of these people were identified from past research as high risk. So this particular trial was testing the cabotegravir injection compared to the daily oral TDF-FTC drug. And I'm so it's just very fulfilling to have worked on that project, because the clinical trial data showed that the injections were working very well, and the FDA licensed the drug to go on market. And yeah, I mean, that really makes me happy that I was part of that work. And, just interacting with these participants and seeing that I'm doing work that is helping their lives get better, that is helping to protect them from conducting HIV/AIDS was very, very fulfilling. Next slide, please. Yes, so during the COVID-19, in the middle of the COVID-19 pandemic, I also worked on 2 phase 3 randomized COVID-19 vaccine trials. One was looking at the safety and efficacy of 2 versus 3 doses of a SARS-CoV-2 mRNA vaccine in a population of immunocompromised individuals. And specifically, we're looking at people living with HIV/AIDS, since that was the main target population for our organization. And the other was looking at the safety and efficacy of a monovalent versus a bivalent adjuvant recombinant protein vaccine. And it's a lot of biology, and I'm not a biologist myself. And like Corinne said, the biostatistics field doesn't require you to have technical skills in biology, but just understanding how the biology is playing and bringing the statistical point of view to it. So these 2 studies, by the time I left to come to Berkeley, they were still ongoing, but the preliminary data showed that the vaccines were working very well. I also worked on some community-based projects, and one of them was CVAC, and CVAC's main aim was to assess the knowledge and perspectives of HIV vaccine trials for community engagement strengthening among fishing communities. And I think one of the reasons why we decided to work on CVAC was because we realized most of our participants, even when they had participated in the vaccine trials, they barely had any information about what an HIV vaccine trial is, what is going on, and we realized that there was a knowledge gap and we needed to assess how big it was and what we can do to empower the communities so that they feel more involved in the kind of work that we were doing, and have more knowledge about the kind of work that we were doing. And one of the things I did for this particular study was designing the survey tools. Yeah. So how did I find my path? When I was preparing these slides, I particularly chose this picture. It was very interesting because I believe that many of us have been here before, or if you haven't, you'll probably be at some point. And if you'll never be, then you're very lucky. But personally, as I was growing up, I thought I wanted to be an engineer because both my parents were engineers. So I thought that by default, I would also be an engineer. But as the time went by, I discovered that engineering was not something I wanted to do. And then I discovered that I had a passion for healthcare, for health, human health, but I didn't exactly want to be a doctor. I didn't have the courage and strength to go and cut people up and inject people. I feared hospitals myself. Yeah, so I kept asking myself, what is that thing that I can do to contribute to the healthcare industry, but without necessarily being a frontline medical person? It took me a while. And one of the things that I did, next slide, please. So one of the things that I did was observation. And in 2017, my mom was diagnosed with stage 4 cancer, and it was a relapse because she was first diagnosed in 2010 and then went in remission, and then the cancer reoccurred in 2017. And around the time I was at the university, and I remember going with her for her medical appointments at the Uganda Cancer Institute for treatment. And as I would sit around in the lounge as we're waiting for the doctors, or when we're admitted on ward, I just kept observing how the vast amounts of data that was being collected from the patients. And being that cancer is a chronic illness, most of these patients had been at the institute for a long time. So there was a lot of data. My mom had a very big file. And, I asked myself, oh my God, all this data that is in here, couldn't it tell us more about my mom's, treatment trend? Couldn't it inform us more about what better interventions can work for her? And I feel like it would be the same case for all the other patients. Yeah, so that is when I got an interest in data, in understanding the data, in looking at data. And it was unfortunate because the way we were collecting the data in our government hospitals was not, effective for us to be able to analyze it. So most of the African public health institutions do not have electronic health records, which is something that I feel I want to advocate for as a person, because I believe that with that, when we have data collected in an electronic form, then it can help us with the analyzing. And definitely, like Corinne talked about, observational data, there's lots of things that we can learn and be able to make more targeted interventions, discover what is working and what is not working, so that we can do things differently and see a healthier population. Yeah. Next slide, please. So the other thing that led me to my path was curiosity. So like I said, when I joined a clinical trials organization as a mathematician, everything was so new and I was curious. So because we're collecting lots and lots of data, and then would, put it in the EDC systems and then submit it to the protocol team, and the protocol team would, write and tell us, hey, you know what, according to the data that we have collected so far, this drug is working. For me, it seemed like magic. Like, how are they doing that? How are they reconciling the risk score and the, all the chemistries and the hematology results. And then they're like, oh, the drug is working, I was really interested to find out how, and I was asking myself, how do you, conclude interventions work or they don't work? How do you make sense of biological data? Next slide, please. Yeah, and I finally found my answer, and that was biostatistics. Yes, and like Corinne has shared earlier, biostatisticians develop and apply statistical methodologies to better understand data from scientific research in biology, medicine, and public health. And for me, because it was really targeted to health, it was the thing that I was looking for. So I was like, okay, finally, it's here. Yeah, and that is when I decided to start looking for biostatistics programs to apply to. And I was fortunate that the biostatistics program at Berkeley really resonated with my interests, the research that the faculty were doing, especially in HIV, was similar to what we were doing back home. So I was like, yeah, this is the place for me to be. Next slide, please. Yeah, so I started out my application to UC Berkeley in 2021. Yeah, actually, by the time I watched the information session recording, I had just finished my GRE exams and I was not sure I had done well. And I remember Corinne, talked about the different requirements and the percentile in which, you need to be competitive admission. And it really allayed all my fears and insecurities about the program, if I was good enough to apply to this program. And I remember after that, I was more confident and I went ahead with the process. I also reached out to one of the faculty members and she was very responsive, which was, very, very encouraging for me to continue through the process. I am thankful to the program manager, Lauren, kudos, shout out to you, and all the faculty that have been that were very supportive throughout the process, that made it easier for me to navigate. Next slide, please. Yes, so how has my life been so far? Like I said, I've been here for 2 months and it has been wholesome. Like there's been lots of things, but one of the things I love about the program is the flexibility that comes with a wide range of classes to choose from, which gives you an opportunity to explore your interests, but to also discover new ones. So there are lots of opportunities for you to learn what you want. I'm personally interested in clinical trial design, and I'm happy to know that there are lots of classes for me to do that. I'm interested in machine learning, and I've so far taken one machine learning class, and it's really, really amazing. There are also supportive peers and faculty, all drawn towards collective engagement and success. It just feels like, a nice, neat family. And I've not really felt different, even because of my skin color, or it's been really inclusive, and I'm really grateful for that. I also love the peer mentoring program where senior students mentor incoming students and help them navigate their journey. It just, gives me the courage that someone has my back, someone has walked this journey before me, and they can help me, guide me, help me not make mistakes that probably they did. And it's really nice to have such a person on your journey. Also, one of the things I look forward to every week are the biostatistics seminars where faculty share their experiences and research, and we get to ask questions. Before the one this week, the previous week, the session we had was with alumni in the industry. It was very, very informative. We got to speak to people. And like Corinne said, the Berkeley alumni get to work in different amazing places. I remember there was someone from Netflix, someone from Genetech, and they're giving us the perspective of how the industry is, which you know is very insightful and helpful as we continue our journey. Yeah, so that has been my path. That is how I found myself here. And I am here to answer any questions in case anyone has questions. Yeah, I'm happy to share more. Yeah, thank you.
Thank you so much for your presentation. It's so fun to hear about your journey, Joy. Yeah. So, Joy, for questions, if anyone has them, do you want them to ask them during this break time, or what timing works for you?
Sure, of course. If they have questions during the break time, it's fine for me. Yeah.
Okay, cool. So we have the scheduled 10-minute break. So if anybody wants to, go stretch, get a drink, whatever you need, get some tea, please do that. Just come back in 10 minutes. So I'm not sure what your local time is, but just 10 minutes from now, we'll be restarting again. But if you do have any questions, it sounds like Joy will be online too. You can ask them in the chat, or feel free to turn on your video if you'd like, or just turn on your microphone. Either way is good. But thank you so much, everyone, for joining us so far, and we'll see you back here in 10 minutes. And thanks again, Joy, for your presentation. Super informative. And when we come back, Andy will be chatting with us about some research projects and his experience so far in the program. I'm gonna myself step away or just to use the restroom. So if anyone tries to talk to me, that's where I am. I'll be back.
Hey, Corinne.
Yes.
Should I just give it a second? I don't know if you're expecting anyone to kind of drop back in.
I think it's good to get started whenever you're ready.
Sounds good. Well, hopefully everyone is back and can hear me. My name is Andy. I'm a second year master's PhD student here in biostats at Berkeley. And I'm going to really echo a lot of what Joy just talked about, namely kind of talking about how I got here and what it's like to even be a biostat student, and just kind of give a little slice of my life here, give you a sense for what it means to be here in this program and what it looks like from a research and a coursework perspective. So yeah, I'll just go ahead and get started. Please, send any thoughts, questions in the chat too, but also we have that section at the end of this workshop to answer questions. So yeah, I'll just get started. This presentation is titled Best of Both Worlds, Biostats at Berkeley. Yeah, I'll talk a lot about why I really do think it's kind of a balance of two things that, I hold truly like close to my heart, and, it might resonate with some of you. So not all of you. Okay, so I'm going to talk about my background and how I got here. I'll maximize this now that we're in presentation mode. Let's see, it's this. Cool. So yeah, talking about how I got here. So I really went through quite a roller coaster of, my majors and stuff in college, and that I started out as a public policy major. I, tried political science. I realized while I love the idea of going into a field that was so direct and like working with direct policy action, something that I thought I was passionate about, I realized, to be honest, my strength is not in reading quickly. So I realized, okay, maybe I try something else, biology. And, I took a bio course my freshman year, found it interesting. So I said, why not try that? And I went on this route for a while, where it led me to kind of start thinking more about maybe I should go into medicine. And we didn't really have a major for that. So I kind of needed to find a way of pairing all these classes that prepared me for medical school with a separate major. And biology, to be honest, was so similar to all the courses I had to take that I ended up actually trying something different, which was statistics. And so statistics really was never kind of my primary focus in college. I started out with the general premise of I want to enter a field that allows me to think about ways I can help people. To put it generally, I wanted to, if you look at all these majors, you can see how they have a general sense of, oh, how can we maybe think about informing policy? How can we affect things maybe related to the environment, related to health? These are all general concepts that I held close to me, and statistics ended up being a field that I chose purely because I found it's pretty general. Maybe I can apply it to different things, but I never really had too strong of a sense of wanting to go in that direction, at least initially in college. So it really started to hone in for me what I wanted to do as I took on different roles as an undergrad. I was a research assistant in an environmental health lab, and that was really interesting. I remember seeing the job posting talk about how the lab was looking at fisheries across the world and changing nutritional yield as fish populations decline due to climate change. And all these things were very much both interesting, but also important for me, thinking about how climate change affects communities, thinking about things on the global scale. These questions absolutely excited me. So it allowed me to be in a role where I could do some descriptive work. Here, the work while dealing with data wasn't really as heavy on the modeling aspect, or kind of the more thinking about questions more mathematically. It was more, how do I take the data I have and maybe provide some summary statistics, some visuals that help us paint a big picture. And that was a role I really enjoyed. A lot of it did involve what you might recognize in a lot of positions as an undergrad research assistant, which is a lot of data organization, data cleaning. And these things you'll know very quickly are really important for any field, just because here is where the bulk of your time is actually spent. And but this is where I started, very much from this kind of early stage of the data analysis pipeline. So I graduated and in 2018, and I didn't know what I wanted to do. I applied to a few jobs, all related to the general field of data science, but again, wanting to do things in the application of policy, health, things that I, was interested in improving, essentially. And I was very fortunate at the time. My partner was in a jiu-jitsu class, and she had a sparring partner who happened to mention that his lab had an opening for a data analyst, and that led me to this position. So it was incredibly coincidental, but also, I just by putting myself out there as someone who was looking for this role, it naturally happened. And it ended up being really a really good fit for me. I was looking at patients all across the greater Boston area and thinking about how there are a lot of health disparities, and thinking about how cardiovascular health in general is a widening field of where there's a lot of opportunities for data science and a lot of questions to be answered. So this is really nice for me. I finally got to be a bit more statistical, and this is kind of around the junction point where I was having to decide whether I want to go in the direction of medical school or not. And I think from here, it became much more clear to me that I was really interested in answering questions. And while I also love the aspect of being able to help people on such a direct level, like you would as a clinician, being able to think about big questions, questions that pertain to entire populations, that was something that really interested me. I think I really like the idea that there were gaps in the literature, thinking about unanswered things that people have not addressed yet, and thinking that'd be really interesting if I could put myself in there. So one project I worked on when I was in this lab was looking at longitudinal data and thinking about how do people age differently, and that resulted in a publication, which was really exciting. Just to be a part of that was a really good experience. So I also joined the second lab. This is right around the time COVID started, and this was a much heavier methodological project. So over time, you can see I went from a data cleaning role in the first lab, and then kind of doing more traditional modeling in the second lab. And by the third lab, it kind of pushed me to think more carefully about the approaches I was actually using to begin with, kind of a meta look at my methods and thinking, kind of reviewing back to work I had done in previous labs to say, were the models I was using correct to begin with? What are ways in which we could improve on those methods? So it became less a question of me thinking, how can I apply my statistical knowledge and quantitative skills to a question, and think even more, are the questions I'm even asking correct? Am I using models that are actually uncovering the truth, or are they just producing, things that I don't actually have a good basis for saying confidently? So I started to kind of have this moment of self-doubt of, am I even producing correct results? Am I even producing things that are real, or am I just excited to publish? So it's these kinds of things that I start to ask myself and doubt my work a lot. And luckily this lab helped me kind of think more carefully about that. And this project I worked on was looking at something that I'm still kind of working on today, which is the field of causal inference, which I'll talk about more later. But just kind of thinking about how when we adjust for variables in a model, are we doing that in a way that is correct? And are there problems inherent to like these traditional methods of doing things? And I thought that was really interesting. And this is the paper that we used to base our whole project on. Anyway, so long story short, my work transitioned from being very applied, answering very direct questions about the data, to much more methodological, which is to say that, my work was much more not even dealing with the questions, but dealing with the way in which I produce those questions and the way I answered them. And I just kind of realized I was starting to be a bit frustrated by seeing how messy actual data is, and knowing that in a lot of my statistics courses, they kind of show us a lot of things that hold a lot of, a whole lot of, really impressive mathematical truth to them, but in real applications, they might have some air gaps and some ways in which they might actually not be the best method to use. So it just kind of put me in a position of wanting to learn more about the models I was using to begin with. And that's where I started kind of exploring options in grad school. And my statement of purpose really was all just about that, kind of describing my shift and how I got here to a place of just being a bit frustrated with the way things were, but in a way that I want to kind of excitedly fix them and address them. So that led me to come to Berkeley, and I since have been fortunate to try so many different things. A lot of my coursework has given me a lot of project ideas, a lot of just different attempts to just answer questions. So my main research, though, is that with Professor Alan Hubbard. I'm currently one of his graduate student researchers, which is what GSR is. And DSign is this project that aims to use data science specifically in improving a lot of community health efforts in Africa. And so one of the main projects that I'm on is a project that involves reducing the burden of injuries and other surgical diseases, specifically in the world of trauma surgery. And what we're doing is finding key variables that tell us who, as they come into a trauma unit, how we can kind of quickly characterize their socioeconomic status so that we can be able to find markers of health disparities in each of these separate regions and countries. This is a really, this kind of allowed me to shift back into both an applied and methodological role, where I could think about how can we best answer these questions of clustering patients, but the output is very practical and it's very direct. So again, my role initially was very applied and computational. A lot of it involved writing some code and thinking about how to make all these massive data sets just more efficient so that we can code them up better. And over time, the project started to change in a way I think that melded more with what I was interested in, which is always kind of thinking about how can we make sure that the procedure we even suggested is even correct to begin with. So that's my main role as a researcher here at the university. A lot of these next two projects I'll talk about come from courses that I've taken and the final projects that have come out of them. So one project was for my causal inference course, and the world of causal inference is largely why I joined Berkeley. That is to say, it's for me been a field that has been exactly what I've been looking for in terms of how do we answer scientific questions that are more than just about association, about values that we aren't sure indicate a relationship between things. One thing that I remember working on in my environmental health lab was the field of nutrition, and thinking how is it that we can connect the dots between consuming certain fish to a person's overall health, and thinking how many sources of variation and error might be in that entire pipeline, and feeling very conflicted with wanting to answer that question better. And that's exactly what causal inference helps with, is being more direct about answering those kinds of relationships and figuring things like that out. So the causal project I worked on for this class was on PrEP usage and renal function. PrEP, for those of you who don't know, is a medication that is helpful for being protective of HIV, and renal function refers to your kidney functioning. And there was some controversy with regards to people finding associations between usage of this drug and worsening kidney function. And so me and my group, we were interested in thinking of this as a causal question, which is to say, is there an actual relationship that we can quantify that says taking PrEP leads to an X amount of increase or decrease in kidney function? And that's exactly what we did following the course guidelines. And it was really interesting. The outcome ended up being negative in that we couldn't find a significant association, but that could be due to a lot of different things, such as sample size, such as maybe having better ways of formulating the question over time. So that was a really interesting project, and at least a great exercise to think about how to apply causal inference principles. Another question I answered in class was thinking about sleep patterns in trauma surgeons using wearable data such as Fitbits. These days, wearables collect a lot of information, and when we have a lot of information from one person, that makes analysis different. And sometimes we do a lot of analyses assuming that data is much more neat than it really is. And when we have wearable data, it's pretty tricky to be able to analyze that. So this project involved using this kind of data to show that there are benefits when we can correctly model using a person's individual data as opposed to just kind of thinking about the population that we're looking at, the sample that we're looking at more generally. And we showed in this project that there was a significant difference between those two models, and we were more able to closely find those important differences in how things like hours of sleep would affect a trauma surgeon's heart conditions. So quickly, let me see, we'll quickly go through these next few slides. So my coursework has been really interesting, I think, namely in that they span these three areas. I've been in some applied classes, some more theoretical classes, and definitely some computational courses. And every semester has been a really nice mix of all three of these flavors. For instance, my fall semester, I took the required courses, which was an introduction to probability, introduction to statistics. Both were very more theoretical, helping me think of things in mathematical terms. I took an introduction to computing, which is computational. And then I took a course that is excellent. I think Joy mentioned that she also has been in this, which is kind of thinking about machine learning methods and how we apply them in the field of health. And this has been exercise that's both applied and computational. The next semester, I took analysis of time series, which is thinking about longitudinal data and how we can analyze that. That was very theoretical. The intro to causal inference was both theoretical and applied, gave me opportunity to try answering some real questions. And lastly, the introduction to modern biostat theory. That's very unique to Berkeley's curriculum. That was very theoretical. So where I am now, though, it's been really another great semester. I think what I love about Berkeley is their ability to offer a really diverse range of classes, while a lot of those classes still revolve around the principle of causal inference. And so I took another course in the statistics department this time. I have been taking a course that has been really interesting. It's called statistical consulting. And what that means is a lot of different groups on campus, whether they're in the linguistics department or maybe they're in the Romance languages department, but they have some question that involves a statistical problem or an issue. They email us, and then they schedule a time when they can come in and we can talk about it as a group, which is really cool. And I would recommend, finding that kind of opportunity to be able to talk to people about statistical problems. So I've also taken the biostat methods in survival analysis, which is, again, very theoretical. The weekly biostat student seminar, which is just fun. It's been really fun to learn from my peers about what their work is like. And lastly, I've been taking a music course because it's very flexible here at Berkeley to be able to take courses that aren't all stats. You can take courses that you're interested in as well. So in a nutshell, Berkeley has offered a very lovely learning experience, both in coursework and research. I came in, again, I think I want to emphasize that I came in being much more in the world of health. I was very much committed to being a pre-med student. I wasn't a very strong stat student, and yet, you know, Berkeley was great for kind of getting me to where I am now and giving me support and of making me feel comfortable and making my cohort feel like a lovely group that I can talk to and be open and tell them I need help on this because I'm not good at this. And that was really nice. So yeah, found a really lovely community here, faculty, everyone's very easy to approach. Gave me opportunities to explore and develop great research questions, some that I hope to keep up with, and also opportunities to not just work within biostats, but just work across the field of public health, to work over at UCSF, to work with the stats department. It's just overall very, very lovely. So all that to say, you know, this is just my one road to biostats, and I want to emphasize that it is not clear. There's no one path for sure. I had no idea what biostats was when I came here, but I think it all just stemmed from this desire to wanting to solve real world problems about, you know, people and wanting to find solutions. So as long as that is something you're interested in, then biostat really could be something that is really worthwhile to check out. And so that is my presentation. Thank you all for listening. Sorry I went over.
No, that was great. Thank you so much for telling us about your time in the program and what you've been working on. Super interesting.
Thanks.
Thank
Appreciate
you, Andy.
it. Yeah.
All right, Yutong, I'll turn it over to you.
All right, thanks. Let me share my screen. Okay, you can see this. Okay, hello everyone. So I'm Yutong. I'm a PhD student and also the DI student fellow here in Biostatistics. So today, yeah, I'm like very happy to talk about ethics and algorithmic biases in healthcare and how they're related to like the work of biostatisticians.
It's still showing, it just, at least on my end, says started sharing screen, but it's like a black screen. Do you want to try again?
Okay, let's see. Can you see this right now?
Oh, yep. Awesome. Thanks.
Okay, sweet. Thanks. Great. Okay. And yeah, so then I guess I'll start by talking about, so as I mentioned here, so I'm gonna talk about ethics and algorithmic biases in healthcare. And specifically, I'm gonna start with the first aspect, which is the representation disparity in genetic studies. And of course, I mean, beyond the two aspects that I'm gonna talk about today, there are a lot more interesting problems for biostatisticians to solve related to algorithmic fairness. Okay, so first question would be, why should we care about genetics, or why would genetics be related to public health or human health? So yeah, I think Corinne also briefly mentioned about this at the beginning. So I guess all of us are very familiar with Angelina Jolie. And a couple of years ago, she actually did a genetic test and figured out that she actually carried a mutation in the BRCA1 gene, which is highly associated with breast cancer risk. And so after that, she decided to undergo a double mastectomy as a result. And I think this event is actually very inspiring because it definitely promotes the public awareness of the importance of genetic testing. So yeah, so that's like one aspect of genetics, which is in terms of the genetic testing, it can help us to identify potential health risks. And the other aspect or benefit of genetics is that it can help the doctors to choose personalized medicine that are safer and more effective for each individual patient. So here's like a very short video. I found it to be very fun, so I would love to show that. Let me know if you cannot hear the sound of it.
This is Max.
And this is Hannah. They both suffer from an autoimmune disorder.
Max is a patient today, and his story is based on current medical practice.
Hannah's story is our prediction of what will happen in the future when medicine has become personalized for this condition.
Max's doctor correctly identifies his condition and prescribes the standard first-line therapy, corticosteroids. Max tolerates them poorly and experiences nausea and vomiting.
Max goes back to the doctor, who decides to revise his dose. However, Max still suffers adverse events.
Max goes back to his doctor, who switches him to non-steroidal drugs. The nausea and vomiting subside, but the drugs have limited efficacy. He remains prone to hyperimmune reactions.
Hannah visits her doctor and is also diagnosed correctly. She undergoes genetic and serum protein tests. These establish the genetic cause of her problem and help identify effective and well-tolerated treatments.
Diseases with the same symptoms often have different genetic causes. Genetic tests allow doctors to identify the roots of the problem and tailor treatments to each patient. Further analysis of genetic markers can aid selection of a treatment with minimal side effects.
Hannah's doctor prescribes a genetically tailored drug for her condition. The new medical technology allows the doctor to treat the patient, not just the disease.
Max suffers a hypersensitivity reaction and is hospitalized. His doctor prescribes Imuran after struggling to find a milder therapy which Max can tolerate. This leaves Max prone to cancers.
Hannah's treatment is successful and well tolerated. Her condition is managed effectively.
Okay, so yeah, that's like a very short but very interesting intro about personalized medicine. And yeah, so I guess this is like a very nice summary about why genetics is helpful. But then the next question that you might have is, but why would all that have anything to do with biostatistics? So it turns out that actually without biostatistics, none of those precision medicine would be possible. So here in the figure, the left-hand side is the medicine of the present, where we have the same treatment, which is the green tablet for all the patients. And then the right-hand side, that's the medicine of the future, where we can actually give personalized medicine. But in order to be able to do that, we have to be able to analyze the blood DNA, which correspond to the genetic, and all the like tissue organ data. And only biostatisticians will be able to do such analysis or develop some like biostatistical methodology to model such data. So these are like super important to be able to identify the critical biomarkers corresponding to different kinds of disease. Okay, so that's in terms of the precision medicine part, and biostatistics is also very important for genetic testing. So for instance, you might have already heard of this commercial company for genetic testing called 23andMe. So here on the left-hand side, this is just a screenshot of part of its genetic testing results. So you can see that, okay, after they sequence the genetic data of one individual, then they will be able to report that there's a 45% of chance for this individual to develop type 2 diabetes between the age of 28 and 80. And so how did they get this probability? How did they get this 45%? That's exactly because of the biostatistical models that we, like biostatisticians, developed. Okay. So with all that being said, but there's like still huge problem in genetic testing, especially in terms of ethnicity inequality. And what I mean by inequality is that there's a huge underrepresentation of a lot of the minority populations, especially Black, populations and other people of color in the genetic studies. So here, basically the two pie charts, they're conveying the similar information. The only difference is that the left-hand side, it corresponds to all the studies in the genetic analysis, and then the right-hand side corresponds to the total number of individuals in all the studies that are covered in the figure on the left. But no matter which pie chart we look at, it's very easy, I think, to see that most of the population here, they actually belong to European ancestry. And that means that the results of the genetic testing will most likely to be only applied for the populations of European ancestry. But then for those individuals of different populations, the personalized medicine might be less beneficial for them. Okay, and as 23andMe already acknowledged that such problem does lead to racial inequality. And this is exactly because what I mentioned in terms of the low representation of other populations in the data sets when they were trying to build such genetic tests. For instance, like in terms of their genetic testing for type 2 diabetes, they have actually acknowledged that there is a much lower predictive power for African Americans compared to other groups. And then the problem becomes even more serious because why would we expect that other populations will be willing to participate in the genetic testing from 23andMe? Because it's like a for-profit program and it by a for-profit company, but then those other populations, they actually will not benefit as much from such tests. So basically the problem just will always sustain there. So that means there's a long way to go. So for instance, for the commercial genetic testing companies such as 23andMe, they are actually already trying to collect more data from the underrepresented populations. And on the other hand side, there are also a lot of more like problems or interesting questions for biostatisticians to work on in order to develop better algorithms or methods to correct for such bias. So, okay, that's like one case study. So some other problems include, for instance, in terms of all the clinical trials that will lead to cancer drug approval. So this is a figure that I extracted from a paper published in 2019. So you can see that, okay, among all the 70,000 patients with their ethnicity reported, most of them actually also come from the European ancestry, which means that for most of the FDA approved cancer drugs, they actually have better efficacy, or at least their efficacy is mainly demonstrated in the European ancestry population rather than any other population. And similar problem, like other than ethnicity, which is the gender disparity. So for instance, as we can see here, this is also like a figure that I extracted from another paper published in 2021 for COVID-19 clinical studies. So among all the 4,420 COVID-19 related studies, we can see that almost 3,000 of them did not mention the gender information for the participants. And for the rest of them, only 172 studies reported the gender information, but only like about 178 studies actually included the gender information as their analytical variable in their downstream data analysis. So all that, they're like huge problems. And this is something that we as biostatisticians could do, like in terms of how to solve such problem. Okay, so that's the first aspect in terms of the representation disparity. The second part is in terms of the algorithmic fairness in machine learning. Okay, so here I'm just quoting from a professor, Maurice Hart, in the EECS or computer science department here at Berkeley. So we live in a world full of like inequality, discrimination, and as we use machine learning to try to formalize, scale, or accelerate the processes in this world, we actually run the danger of reinforce the already existing patterns of injustice. And I'm gonna explain more about this in a bit. But the bright side is that there is actually still probably a somewhat fragile opportunity for biostatisticians or all the researchers to revisit our decision-making process to try to aim for the better. So there are like all the resources. If you're interested, you can definitely take a further look into them. So, but basically, okay, in terms of what I meant by reinforcing the discrimination, this is somewhat related to the historical Jim Crow laws, which was trying to like sort of, they have this separate but equal legal doctrine, which was totally wrong. And in some sense, what we're having right now is more like a new Jim Code proposed by Dr. Ruha Benjamin. Basically, the employment of new technologies that reflect and reproduce existing inequalities, but that are promoted and perceived as more objective or progressive than the discriminatory systems of a previous era. So even though there's like embedded discrimination in the machine learning algorithms, but they might justify for themselves, it seems like they are more objective, but that is actually totally wrong. So for instance, I can give you a concrete example in terms of why such machine learning algorithms actually are bad. And one of the most important things is that the failure of the fairness is actually through unawareness. So for instance, here we can see that this is a case study for the Amazon same-day delivery coverage. So for residents of minority urban neighborhoods, access to Amazon's vast array of products, such as like dish soap or some food products or like TVs, they can be very helpful, right? But unlike the wider zip codes, these parts of town often lack well-stocked stores and quality supermarkets. And then people in these neighborhoods, they have to travel farther and sometimes pay more in order to obtain those household necessities, as I mentioned. However, it turns out that when data analysis tried to look at the Amazon same-day delivery coverage area, they figured out that actually the service area excludes predominantly Black zip codes to varying degrees. So for instance, as in the figures that we can see here in Atlanta and in New York City, so the blue area gets the same-day delivery, and they're actually mostly the white zip codes, but then the gray area, they don't get the same-day delivery, and they're actually most the more like zip codes of color. So definitely, I mean, like no one will think that Amazon was trying to like embed the discrimination in their algorithm. Maybe they were just trying to predict the number of purchases, which somewhat correlates with the race in the United States. And it's almost certain that they did not explicitly look at their customers' race when they were trying to build the product. But that's how the discrimination was embedded through this unawareness. This is another example in terms of the machine bias. So there's a software that's used across the country to predict future criminals, and it's also biased against the Blacks. So for instance, here we can see two individuals. The person on the left is called Parker. He was rated as high risk by the machine learning software. And the person on the right is called Dylan. He was rated as low risk. But actually both of them, they did the same thing, which was shoplifting for about $80. And then actually 2 years later, we can probably already know what happened. So it turns out that the computer algorithm got it exactly backward. So Parker on the left, he didn't commit any new crime, but Dealing on the right, he actually committed much more serious subsequent crimes. So scores like this, which are known as risk assessments, they are actually already used to inform decisions about who can be set free at every stage of the criminal justice system. And because of like such embedded racial discrimination, there is actually a huge concern in terms of how we could eliminate such racial discrimination. Okay, and there's another similar case study in terms of the gender disparity, but for the sake of time, I'm probably just gonna skip this, but if you're interested, you can definitely look into the gender shades projects. Okay, so to summarize, the takeaways is number one, biostatistics is super powerful. As we already saw, like it's very important in terms of like all the different aspects in healthcare, such as genetic testing, precision medicine, and a lot more. The second is there are still a lot of challenges which might lead to potential ethnic and algorithm biases. And last but not least, you can become a biostatistician and work on these exciting questions and try to contribute to healthcare and social equalities. All right, thanks. Okay, that concludes my presentation.
Thank you, Yutong, for your presentation and sharing that with us. Appreciate it. Okay, cool. So we have about 20 minutes, and I see that Lauren Krupa's on the call as well. And we're happy to answer any questions you might have. Lauren, do you want to just give a quick background about who you are?
Sure. My name is Lauren Krupa. I am the Senior Program Manager with the divisions of epidemiology and biostatistics. So I oversee the programs in both divisions if kind of folks are considering both. Corinne kind of straddles the line a little bit too sometimes with epi and biostats. And so if you sent emails over to the divisional email, the biostatistics email, things like that, you probably have emailed with me. Samaya was our grad advisor. She's gone off to grad school, and so we're hiring for a new grad advisor. So you can't get away from me. So if you have any questions about the application process in particular, or any like hiccups with it, I'm the person you want to talk to. So I can definitely help with any of those like more practical issues. On my day-to-day I work directly with the students doing academic advising, a little bit of curriculum management and scheduling, and then financial aid stuff. So also questions regarding that.